In this presentation, we are going to learn about the relationship between cardiac output and the filling of the ventricle. This was explained by two scientists from the UK and Germany and therefore named the Starling law. It is important to have a very good understanding of this relationship as it has very important clinical applications in our day-to-day life. In short, Starling law means that within physiological limits, the force of contraction is directly proportional to the initial length of the muscle fiber. It highlights the fact within physiological limits, which is very important because when it goes outside the physiological limits, this relationship changes. What Starling described is very much similar to what we observe in a catapult. If we stretch it more, we can shoot to a greater distance. However, there is a limit. If we stretch it too much, it can break. The same applies to the ventricular myocardium. Even though it does not break, if you stretch it too much, it will become less efficient in contraction. We will discuss this in detail to understand it better. To generate some interest, we will discuss a clinical situation first. A newborn diagnosed with a coarctation presents with severe heart failure. He is tachypneic, tachycardic and has poor peripheral perfusion. What should we do at the initial resuscitation? Should we give a fluid bolus? Should we start inotropes? Can diuretics help? What other measures will help to save him? Answering all these questions becomes much easier if we have a proper understanding on how the heart behaves in heart failure. We will discuss the answers at the end of this presentation when you have a proper idea about the pathophysiology of this condition. Going back to Starling law, we will start with the history. Otto Frank from Germany, born in 1865, and Ernest Starling from the UK, born in 1866, described this physiological principle on the response of the heart to filling. They did not do it together but did it separately in two countries and about 5 years apart. Ernest Starling, occupying 2 years of his life, 1910 to 1912, concentrated on how the heart increased its output in response to more blood entering into it. For this work, he made use of anesthetized dogs. However, Starling was unaware of the work done by a German physiologist, Otto Frank, before him on the same subject using the isolated frog heart. Frank in 1905 to 1908 showed that longer the heart muscle fibers were stretched, the stronger the contraction. He used an isolated frog heart for his experiments. He did this with no interest in the circulation as a whole. Therefore, Frank's findings has to be taken in parallel with Starling's, so it became the Starling law. What is actually meant by the Starling curve? We will learn it in a simplified manner and learn how to apply it into our day-to-day clinical practice. Before we do that, we need to refresh our knowledge on the cardiac muscle because Starling law is all about cardiac muscle. We will try to refresh our knowledge on anatomy, components and how it functions. If you take a small part of cardiac muscle and enlarge it, you will see the cardiac muscle cells or cardiac myocytes, which make up the cardiac muscle. If you further enlarge it, you will see that each myocardial cell contains myofibrils. These are long contracting elements and each myocyte has a number of myofibrils. If you further enlarge a myofibril, you will see that they have segments called sarcomeres. It is the segment between two Z discs. These sarcomeres are the fundamental or basic contractile units of muscle cells. Within these sarcomeres, there are a number of proteins. Out of that, there are 3 long proteins that play a major role in cardiac muscle contraction. They are called actin, myosin, and titin. These proteins are organized into thick and thin filaments called myofilaments. Actin forms thin filaments and myosin forms thick filaments. That is about the anatomical arrangement in cardiac muscle. Next, we will see how it functions to make effective contractions. Muscle contracts by sliding the thick filaments and thin filaments on top of each other. Thick filaments are myosin and thin filaments are actin. If you look at this diagram in detail, you will see that there are actin and myosin in long lines, and titin keeps myosin in place. When activated, myosin heads bind to actin and pull actin closer to each other. This shortens the sarcomere length and in turn the length of the myofibril and the myocyte. This is how a cardiac muscle contracts. We will try to simplify it further. This is a simplified diagram to show the relationship between actin, myosin and titin. We will dissect and see how this element really works. First, the myosin. Myosin is a long protein and it is organized into thick filaments along the myofibrils. There are myosin heads that bind with actin to pull actin together. Around myosin you get actin, another long protein arranged in a longitudinal manner in the myofibril. These form the thin filaments. Actin filaments are anchored to C discs. These appear as dark lines in cardiac muscle. Titin is another large protein in cardiac muscle. It binds myosin to C discs and helps to keep myosin in place. The length between two Z discs is called the sarcomere, which is the primary contractile element of cardiac muscle. When myosin heads bind and pull actin together during contraction, the distance between the two Z discs shortens. In other words, the sarcomere length shortens. This is how the cardiac muscle contracts. Now you know the basic arrangement in cardiac muscle. With that, we will proceed to understand how it contracts at different levels of stretch, which is the principle of Frank-Starling law. Even though there are many actin molecules around each myosin molecule, you should note that any myosin molecule will not get bound to any actin molecule around it. There is something called polarity. These myosin heads will bind to this actin and will pull in this direction. These myosin heads on the other side will bind to that actin molecule and will pull in that direction. This pull in the opposite direction will bring the two Z discs together, shortening the sarcomere, which will in turn shorten the myofibril and the myocyte. This is how cardiac muscle actually contracts. Now we will apply that knowledge on the anatomical arrangement of cardiac muscle and its contraction to understand what really happens in the Frank-Starling principle, which was explained by Otto Frank and Ernest Starling about 100 years ago. According to Frank and Starling, the force of contraction of cardiac muscle is directly proportional to the initial length of the muscle fiber. Now we will apply this principle to the left ventricle. According to this principle, if the left ventricle is less filled, the cardiac muscle will be less stretched and therefore the force of contraction will be less. If we continue to fill it, the cardiac muscle will stretch more and more and the force of contraction also will gradually increase. But according to Frank and Starling, all this is up to a limit, which is the physiological limit that the myocardium can stretch. This graph represents what Frank and Starling said. On x-axis, we have the maximum volume that the left ventricle can achieve. As the left ventricle fills during diastole, it achieves its maximum volume at the end of the diastole. Therefore, it is called the left ventricular end diastolic volume. We will plot that left ventricular end diastolic volume on the x-axis of this graph. On y-axis of the graph, we will plot the stroke volume, which is the volume of blood that is ejected out of the left ventricle in one cardiac cycle when it contracts. To explain this principle, we will go through 4 levels of filling of left ventricle, 3 physiological and 1 pathological, and compare what happens to that stroke volume or contractility of the ventricle in each situation. At the first level, you can see the ventricle is heavily underfilled. At the second level, it is better filled, but it has room for improvement. You can fill it more. At the third level, it is filled to its best possible physiological limit. At level 4, we have filled the left ventricle even more and it has gone to the pathological area of the curve. The first case scenario is a patient with a very low left ventricular end diastolic volume due to severe hypovolemia. This may have occurred as a result of dehydration, acute blood loss, or excessive diuresis. We will discuss in detail the behavior of the cardiac muscle in this situation according to Frank-Starling law, how to diagnose the situation, how to treat, and how to assess response to treatment. First, concentrate on the actin and myosin diagram. When the ventricle is almost empty, there is overcrowding of myosin and the actin is overlapping. Because of this, there is hardly any space for myosin heads to bind with actin. As there is overcrowding of myosin, the space between the two C discs is already low. There is no space for it to contract and come together. Therefore, when the muscle contracts, the distance that C discs can move is minimal. Therefore, the force of contraction is low, and because of that, the volume of blood ejected into aorta, we call it the stroke volume, is less. For you to understand this better, we will continue to do some mathematical calculations in all four scenarios. In this first scenario, we will take the left ventricular end diastolic volume as 50 ml. Out of that, 30 ml will be ejected into aorta when the ventricle contracts. Therefore, at the end of contraction or end of systole, 20 ml will remain in the left ventricle. So calculated ejection fraction will be 60%. There is no point in learning theory if we do not apply it in our day-to-day practice. So how do we identify a patient in scenario 1 in our day-to-day practice? The first and foremost is the history. Please get a detailed history to look for dehydration, poor food intake, diarrhea, excessive diuresis, acute blood loss, or any other condition that can deplete the intravascular volume. When you examine the patient, you should first look for features of the cause for this presentation, features of dehydration or features of acute blood loss. The second step is to look for clinical features that will indicate the severity of the volume loss. If it is mild to moderate loss, you will see only features of low cardiac output and features of compensation. Pulse volume will be low and blood pressure will be low normal because of compensation. You will also see features of compensation like tachycardia and vasoconstriction due to the activation of the sympathetic nervous system. If the volume loss is severe, you will see features of decompensation. In this, there will be features of poor organ perfusion like reduced urine output and reduced sensorium. If the condition progresses, organs will change their metabolism from aerobic metabolism to anaerobic metabolism due to low perfusion and low oxygen delivery. This will lead to acidosis. However, as this is a low volume condition, you will not see features of congestion like hepatomegaly or pulmonary edema. The absence of these features of congestion will help you to confirm this diagnosis of low circulating volume. Next, we will see how investigations will help you in this condition. If you do a simple chest X-ray, you can easily confirm your diagnosis. There will be a very small heart with oligemic lung fields. Lung fields will appear black due to low fluid volume in the lungs. If you do an echocardiogram, you will see an empty ventricle. When the ventricle becomes empty, the wall of the ventricle appears thick. This is like a deflated balloon. When the balloon is deflated, the wall appears thick. Similarly, when the ventricle is empty, the ventricular wall also appears thick. You should not fall into the trap where you think that there is ventricular hypertrophy. If the ventricle is extremely empty, you will see that the walls of the ventricle touch each other at the end of systole, which is known as kissing ventricle. If you look at the IVC, you will notice that the IVC is empty and collapses during inspiration. However, to identify this scenario, an echocardiogram is not a must. You can use a simple ultrasound scan machine if you are in an ICU, or can make a tentative diagnosis even with clinical history and examination alone. If you can get a chest X-ray, it will support your diagnosis. The response to treatment is the best way to confirm your diagnosis. So how do you treat? A fluid bolus or a blood transfusion, depending on the cause, is the best form of treatment. If the patient is on diuretics, you might have to stop it. With this fluid replacement, the patient will go into scenario 2 or 3 based on the volume transfused. If you do an over-enthusiastic transfusion, he may even go to scenario 4. When you go through these scenarios, you will understand what it means. Now we will see how to assess the response to treatment. Heart rate is the best indicator to assess the response when we give fluids or blood. Heart rate should drop with fluid administration. With the administration of fluid, we increase the left ventricular end diastolic volume and shift the patient to scenario 2. As the stroke volume is higher in scenario 2, the heart rate will drop, because to maintain the same cardiac output, now the patient does not need a higher heart rate. Other clinical features are improved peripheral perfusion and improved pulse volume. If you do a chest X-ray, the heart shadow will appear bigger compared to the previous, and the lung fields will appear normal instead of oligemia. If you do an echocardiogram, you will see normal sized cardiac chambers, and there won't be any ventricular hypertrophy. IVC will appear to be better filled and will not collapse on inspiration. If you see all these features after the administration of fluids, your diagnosis was correct. He was in hypovolemia, and the low cardiac output was due to hypovolemia. Now we will assume that after the administration of some fluids, the patient has gone into the second scenario. So what happens here? In this second scenario, the patient has a larger left ventricular end diastolic volume compared to the first scenario. We will assume that his end diastolic volume is 80 milliliters now. Therefore, the cardiac myocytes and the myofibrils within it are stretched. This eases out the overcrowding of myosin and exposes more myosin heads to bind with actin. Therefore, when it contracts, the C discs move a greater distance. This leads to a greater force of contraction, and as a result, a larger volume of blood will be ejected from the left ventricle. In this example, 50 ml gets ejected into aorta, 30 ml will remain in left ventricle at the end of systole. His ejection fraction will be around 60%, but the stroke volume has increased from 30 ml in first scenario to 50 ml in second scenario. A patient in second scenario will have a larger left ventricular end diastolic volume and a larger stroke volume compared to a patient in the first scenario. The reason for this is the exposure of more myosin heads to interact with actin when the myocardium is stretched. However, you can see on the Frank-Starling curve, there is more room for improvement. We will give some more fluid or blood and shift him to the third scenario. At third scenario, he will be at the optimum capacity in the Frank-Starling curve. His LV end diastolic volume is 120 ml now. He has reached the maximum limit of left ventricular end diastolic volume, where he can continue to increase his stroke volume. This is the maximum physiological limit explained by Frank and Starling. At this, the myocyte and the myofibril within it are further stretched due to the larger volume of blood in left ventricle. With this stretching, more myosin heads are exposed to bind with actin. The C discs are further apart, so during contraction, they can have the maximum movement. Because of all these facts, we can consider this as the maximum physiological level of the stretch, where the ventricle is able to pump out its maximum stroke volume when it contracts. So a ventricle in third scenario will eject 70 ml of blood into aorta when it contracts. At the end of systole, the ventricle will have 50 ml remaining in it. calculated ejection fraction is still around 60%. This is the maximum level the left ventricle can stretch within physiological limits. So what happens if we stretch it further by giving more volume? It will go into fourth scenario, which is beyond its physiological limits. In the fourth scenario, the ventricle has stretched beyond its physiological limits and has gone into the pathological area. The left ventricle has stretched beyond its capacity, and therefore the myocytes and myofibrils within it also has gone beyond its limits. Left ventricle has reached 150 ml at the end of diastole. If you analyze the arrangement of actin and myosin, you will see that the stretch is so much so that the actin molecules have gone beyond the contact point of myosin heads. Therefore, myosin heads are not in a position to pull actin efficiently. When the ventricle contracts, the strength of contraction is less and therefore the stroke volume is also less. In scenario 4, when the ventricle contracts, it will push only 50 ml of blood into aorta, leaving 100 ml back in the left ventricle at the end of systole. Actually, this stroke volume is similar to the stroke volume in scenario 2. There are many examples for this fourth scenario: inadvertent fluid overload, severe left ventricular dilatation due to mitral or aortic regurgitation, dilated cardiomyopathy, myocarditis, acute myocardial infarction are some examples where the left ventricle becomes overstretched. With this, we have completed 4 different scenarios where the left ventricle is stretched to different levels. We have also learned how the stroke volume changes in each scenario based on actin and myosin interaction. In the second part of this presentation, we will try to understand more about Frank-Starling curve and its clinical application. For example, we know that in scenario 2 and scenario 4, in both these conditions we have the same cardiac output or same stroke volume. But how do we differentiate scenario 2 from scenario 4 in our day-to-day practice? All these things will be discussed in part 2 of this presentation.